Welcome back to the Explainer, everyone. Ever stare at a provider's chart and just second guess your risk level coding? Yeah, we've all been there. Today, we're doing an intensive deep dive into Element 3 of medical decision making under the CPT 2026 guidelines. This element evaluates the risk of complications, morbidity, or mortality, and it's honestly one of the most absolutely crucial and sometimes confusing parts of your daily coding practice. We're going to break it down so clearly that you'll have total confidence the very next time you open a chart.
So here's our roadmap for this explainer. We'll start by decoding element 3, risk. Then we'll cover minimal and low risk, move into moderate risk and SDOH, tackle high-risk management, and finally, sort through those intensive monitoring nuances.
All right, Section 1, Decoding Element 3 Risk.
Okay, so one of the absolute biggest traps in medical decision-making is mixing up the condition with the treatment. We literally have to separate the intrinsic risk of the patient's underlying condition from the risk of the actual diagnostic or treatment decisions we make during the visit. A patient might have a highly complex, severe disease, but if the management decision today is simply to continue a safe over-the-counter vitamin, well, the management risk for today's encounter is totally different from the disease's overall risk.
Element 3 is really all about assessing the probability and the severity of the consequences of our management decisions. And here's a fantastic little detail. It actually includes options considered but not selected. Think about it. If a provider discusses admitting a patient to the hospital, but after shared decision-making with the family, they decide on outpatient palliative care instead, that high-risk consideration still absolutely counts toward your risk level.
Moving right along to Section 2, minimal and low risk.
Minimal risk basically means there's a super low chance of causing harm or complications. Think of this as your basic self-care and extremely conservative management. If the provider is advising rest for a viral illness, recommending saltwater gargles for a sore throat, maybe applying an elastic bandage for a mild sprain, or using a superficial dressing for a minor scrape, you're looking at minimal risk. The intervention itself carries virtually zero threat to the patient. Stepping up a notch to low risk, the chance of harm is there, but it's still, generally very safe. Standard examples here include recommending over-the-counter drugs like paracetamol or ibuprofen. It also includes minor surgeries where the patient has no identified risk factors, like a simple skin tag removal. Sending a patient to physical or occupational therapy, or administering plain, normal saline IV fluids without any active drug additives also firmly lands you in the low-risk category.
All right, Section 3, moderate risk and SDOH.
Moderate risk is literally the bread and butter for a lot of clinics out there. Notice that actively starting a new prescription drug, adjusting a dose, or even managing refills with active assessment automatically elevates the patient management risk to the moderate level. This level also includes minor surgeries if the patient has risk factors, like a bleeding disorder, or deciding on an elective major surgery, like a joint replacement, in a perfectly healthy patient.
But here's a huge coding nuance introduced in recent guidelines: social determinants of health, or SDOH. These are the economic and social conditions that influence a patient's health. If the provider's diagnosis or treatment plan is significantly limited by these factors, that automatically qualifies your patient management as moderate risk, regardless of the clinical intervention itself. So if the documentation explicitly shows that economic hardship, housing insecurity, homelessness, or low health literacy is actually preventing the patient from following the ideal treatment plan, you code this element as moderate. For example, if a provider wants to prescribe a specific medication, but the patient just cannot afford it due to extreme poverty, or they can't attend follow-up physical therapy because they completely lack transportation, that limitation must be documented. Once it is, boom, you're at moderate risk. Next up, Section 4. High-risk management. High risk means exactly what it sounds like. The condition or the treatment involves a high chance of serious outcomes, up to and including death. But remember, providers assess risk based on clinical judgment, not just raw statistics. This means even a very low probability of a severe outcome, like death, still firmly counts as high risk, simply because the consequences are so extreme and catastrophic if they actually do happen. So what does high risk actually look like in a chart? Well, it's deciding on an elective major surgery for a patient who has significant risk factors, like a severe cardiac history. It's emergency major surgery, like an appendectomy for a ruptured appendix. It involves high-stakes interventions, like escalating care to the ICU, or conversely, making the really heavy decision not to resuscitate or to de-escalate care due to a poor prognosis. Administering injectable parenteral-controlled substances, like IV narcotics, also instantly places the management into the high-risk category because of the severe risks of respiratory depression or dependency.
And finally, Section 5, intensive monitoring nuances.
You're going to see the phrase drug therapy requiring intensive monitoring for toxicity claimed as high risk all the time. But to actually count, the drug therapy must specifically require intensive, generally accepted monitoring for severe adverse effects and toxicity, not just to see if the drug is working. We're talking about heavy hitters like warfarin, powerful immunosuppressants, or chemotherapy agents, where the margin for error could literally be life-threatening.
This right here brilliantly illustrates the strict difference you absolutely need to look out for. Monitoring for cytopenia, which is a drop in blood cells during chemotherapy, is classic toxicity monitoring, and it definitely counts as high risk. But checking blood glucose levels for a patient on insulin therapy, that's primarily monitoring for efficacy, just to see if the drug is actually controlling the blood sugar. That does not qualify for high risk unless severe hypoglycemia is a current, significant, and documented concern for that specific patient. You've got to know the difference between toxicity and efficacy.
At the end of the day, vague notes fail audits. It all comes down to the ink on the page, or, the text in the EHR. You have to ensure the provider explicitly documents their thought processes, the risks they considered, the alternatives they weighed with the patient, and the clear medical necessity of their management choices. If they're monitoring for toxicity, they need to actually say what toxic effect they're monitoring for. Good documentation is literally the only thing that supports these codes when the auditors come knocking.
By mastering these distinctions between intrinsic and management risk, between efficacy and toxicity, and by really recognizing the power of SDOH, you're going to navigate Element 3 with incredible accuracy. But I want you to ask yourself, if an auditor pulled your clinic's charts right this second, would your provider's documentation actually hold up to these standards? It's something to think about. I hope this clarifies Element 3 for your daily coding practice, and as always, don't forget to like, share, and subscribe to Decode Healthcare with Harshal.